Hello, my name is Dr. Bethany Murray, and I'm going to be speaking today about teaching telemedicine, patient interviewing in preclinical medical education. Technology is here to stay. This can be difficult for new students who have not had the opportunity to learn how to give full attention to the patient. Students need to have some education and practice and communication skills. This was a quote from one of our volunteer patients in October of 2020. Following this session, participants will be able to discuss the utility of teaching telemedicine to augment clinical interviewing skills in preclinical medical students, to identify best practices in telemedicine use for medical education, and lastly, to identify problem areas when designing curricula that use telemedicine. Let's look a little bit at some of the literature. Telemedicine use has grown exponentially this year due to COVID-19. 76% of US hospitals offered some sort of telehealth services by mid-2020, with predictions that virtual visits would surpass 1 billion by the end of the year. Telemedicine access provides much needed services to marginalized, rural, and underserved communities. However, provider concerns have typically included quality of care, access to the technologies by both provider offices and by patients, patient consent, privacy and security concerns, licensure requirements, legal regulations, reimbursement inconsistencies, and the impact of using electronic technologies on patient and provider relationships. 81% of Americans now own a smartphone. 75% have a desktop or laptop computer, and around 50% have tablet computers. 83% of consumers were interested in receiving virtual care in 2019, but only 17% were offered it by their providers. Of course, this was pre-COVID-19 pandemic. Medical malpractice cases related to telemedicine visits have not increased as compared to face-to-face visits. Medical education in telemedicine is not currently adequate. Students need to learn new skills in order to use the technologies with knowledge and confidence. Training during preclinical undergraduate medical education years allows all students to have exposure. Skills to be taught can include effective communication over the internet, professionalism, history-taking practice, and acquiring clinical reasoning skills. Knowledge and confidence in using telemedicine will increase with careful curricula preparation and planning. So let's talk about our project. Preclinical phase 1 students at the IU School of Medicine spent a semester learning comprehensive interviewing and history-taking skills. In 2020, the IU School of Medicine was forced to move to an online format on November 1st for much of its academic year due to the COVID-19 pandemic. While small group meetings were permitted in the fall of 2020, standardized patient practice sessions for the students were restricted to online only. The Bloomington campus during this time solicited adult volunteers from the community to act as patients for the purpose of practicing the medical history. 34 first-year students interviewed volunteer patients and obtained comprehensive medical and social histories using telemedicine methods. A total of 102 interviews were completed. These were with complex individuals with real-life health problems that they were willing to share with the students. Volunteers were sought by word of mouth and also by placing a notice in the local LGBTQ+ newsletter in order to increase diversity. 22 individuals responded and agreed to be interviewed one or more times. Interviews were completed via Zoom. Faculty ensured that no students interviewed the same volunteer more than once, and each student had 3 history-taking interviews to complete. Volunteer patients were offered Zoom training 2 weeks prior to the interviews. This ensured that they had the hardware necessary at home and also helped to troubleshoot any software issues. Confidentiality was maintained by using only initials in the students' write-ups. Only the lead faculty and administrative assistant were aware of the full names of the volunteers unless they chose to share them. During the Zoom training, volunteers were instructed on how to change their names on the window screen so that they could appear anonymous. Faculty used a common Zoom room for starting sessions and then used breakout rooms to match students with the volunteers. The volunteers were asked to remain in their own breakout rooms while the students were rotated between interviews. The lead faculty person acted as a monitor and remained in the main Zoom room for managing the traffic flow and helping people to enter and leave the sessions. Students were required to dress professionally, wearing their white lab jackets, and to manage the interview as though they were practicing in the clinical setting. They were required to prepare in advance and have outlines on paper for taking notes. They were also asked to inform the patients that they would be taking notes during the session. At the completion of the interviews, both students and volunteers were asked to provide feedback via a Qualtrics survey. Student survey questions were as follows. Did you have any problems or issues with the technology for your interviews? As you can see, 82% of the students reported they had no technological problems. Then lastly, they were asked to describe a positive experience, a negative experience, and to give any advice or suggestions for future telemedicine interviews. Students said that they enjoyed finding mutual interest with their patients. They liked receiving positive feedback from the patients and feedback on how to improve their communication skills. They found the patients to be role models for healthy aging and found this activity a good opportunity to practice history-taking skills. Negative experiences included inconsistent internet connections for a few, not prepared for the patient to talk about highly charged emotional issues, including death, running short on time, starting late, which was primarily a problem with patients' connectivity and arrival times, discomfort with talking to patients about gender pronouns, and difficulty in assessing the patient's body language. Students suggested that they have better preparation beforehand, that they know what is expected of them, and they have more education specifically about telemedicine. They did have one short online module to complete prior to the experience. However, there was no quiz or evaluation for that module. Students also wanted more practice with sexual history and more time to do the interviews. They suggested that other students just focus on staying relaxed. The volunteer patient survey questions were as follows. First, we asked, how long have you been a part of the medical school program as a volunteer patient? And as you can see, half of the patients were new to the program, whereas over 36% of them, or just over a third, have been volunteering with us for 6 or more years. We also asked, why did you choose to participate as a volunteer patient? And did you have any problems with technology? 79% of our patients also reported no problems with using the technology. They were also asked to describe positive, negative experiences and give advice or suggestions. Volunteer patients said that volunteering made them feel useful. They want to give back to the medical field. One of them had a son in medical school. They enjoyed working with students or being an educator. Several of our volunteer patients are retired nurses, and several felt that they had a lot of medical issues to talk about and share with the students. They felt the students were professional and personable. They felt that it was fun. It also made them feel good and enjoyed seeing their eagerness to become doctors. As far as negative experiences, there were not very many reported. They did feel that the students did better when they were more prepared and organized. They felt that sometimes there were disconnects between asking questions and processing the information as the students were early in the learning process. Some of the patients felt that they didn't have enough time. And one patient reported that a student who was trying to take notes on a second computer was very distracted during the interview. As far as advice, they felt it would be a good idea to build in more time for the interview, as well as time to provide feedback to the students and give them some advance warning of the types of questions we would be asking. Overwhelmingly, survey responses were positive and the students felt this was a good learning experience. They felt they need a little bit more preparation for telemedicine. And they did feel that telemedicine offered a limited ability to assess body language. Infrequent problems included intermittent internet loss or slow internet. Volunteers overall reported that some students appeared disorganized or were difficult to hear and suggested more preparation and practice before the interviews. Volunteers also wanted more time and the ability to give students feedback. My recommendations are that an introduction to telemedicine should be taught during phase 1 of medical school. Telemedicine preparation should be multimodal and should cover issues such as state regulation, licensure requirements, reimbursement issues, communicating online, professionalism, HIPAA protection, and technologies that can be used. Telemedicine training methods for students might utilize online learning modules, video demonstrations, peer simulations, and history-taking practice with both volunteers and/or standardized patient actors. Lastly, upper-level medical students in their 3rd and 4th year can use telemedicine in a variety of ways, including actual patient visits, consultations with other providers, doing rounds on patients, and home rehabilitation, of which there is some good published data on motivational interviewing using remote technologies. Thank you very much for your attention today. Here's a list of references for this talk, and I will be happy to welcome any questions during the appropriate question and answer time. Thank you.